Hello, this is Dr. Christoph Corell from Hofstra North Shore LIJ School of Medicine and the Zucker Hillside Hospital. Welcome to this educational activity on schizophrenia management. After completing the activity, access the post-test and evaluation form by clicking the red credit button. I encourage you to download the slides, practice aids, and any other activity features that may interest you, and to participate in the Ask the Faculty component.
Okay, so we're going to be talking about existing oral and long-acting injectable therapies for schizophrenia, and certainly physicians have a number of agents to choose from, as well as formulations. So when we look at the oral antipsychotics and examine meta-analyses of head-to-head trials, we see that there are some differences between the antipsychotic drugs, but the differences tend to be rather small. The effect size differences are rather low. So with the exception of clozapine, the remaining antipsychotic drugs do not differ that much in efficacy. In some of the meta-analyses, clozapine didn't appear as superior as it has in some other meta-analyses. I think there are a variety of factors that contribute to that, but in my view, clozapine is still the go-to drug when other drugs fail. We're going to base our choice to some extent on adverse events or tolerability. In the same meta-analysis by Leucht et al. In 2009, again, there were very modest differences in terms of negative symptoms. Unfortunately, this is a domain that still requires a lot more work in terms of developing effective treatments. Looking at total PANSS scores in the more recent meta-analysis published by Leucht et al. In The Lancet in 2013, again, we see clozapine in a somewhat different category and not very significant differences amongst the other second-generation antipsychotic drugs. If we look at the efficacy of long-acting injectable antipsychotics, we see that comparing paliperidone palmitate, olanzapine pamoate, and aripiprazole long-acting injectable, the number needed to treat is similar across these different agents. In randomized controlled trials, we're not able to show a consistent advantage for long-acting injectable drugs in terms of reducing rates of relapse or risk of hospitalization. Although some earlier meta-analyses did show an advantage for the long-acting injectable drugs, a couple of large-scale recent studies did not show superiority, so now the meta-analyses do not show superiority either. And our feeling is that the randomized controlled trial, although it's the gold standard for evaluating the impact of treatments, when it comes to adherence, the controlled trial itself might have an impact on adherence and may not be the best framework in which to examine the potential superiority of a long-acting drug. So the mirror image studies are much more consistent in showing superiority of the long-acting injectable drugs over oral medications. Here we're looking at mirror image studies comparing rates of hospitalization during a specified interval before the implementation of a long-acting injectable drug and comparing that with the same time interval after the introduction of a long-acting injectable drug. And so each patient serves as his or her own control. And here we do see a rather consistent superiority for the long-acting injectable drug. So we might conclude that the methodology that one uses in comparing these agents can have a very important impact on the results. Another way of looking at this is the so-called naturalistic or cohort study. Tahonen and colleagues looked at individuals who were discharged from hospital after their first hospitalization, some of whom were given long-acting injectable drugs and some of whom were given oral drugs. And what he showed was that there were significant advantages for the depot formulation of a particular agent. And this is an interesting finding because, if anything, it's a conservative bias in that those physicians who chose to use a long-acting injectable drug for these patients were probably being guided by some evidence that they had gotten regarding the patient's lack of desire or lack of willingness to continue taking medication or difficulty adhering to the medication. So, if anything, we might expect to see a higher rate of relapse amongst those individuals who were given the long-acting injectable drug. And in fact, those individuals who were given the long-acting injectable drug had a lower rate of rehospitalization. We're looking at data that also came from the meta-analysis by Kishimoto, showing no significant difference in risk of discontinuation between the long-acting injectable drugs and the oral antipsychotics. Here we do see differences in terms of risk of discontinuation. So the naturalistic study is producing data that is much more favorable in terms of showing the superiority for long-acting injectable drugs in comparison to the controlled trials. The controlled trials really change the way the overall treatment is delivered, and that may make it more difficult to detect the signal demonstrating potential superiority for the long-acting injectable drugs. The next slide is an example of medication possession ratio in essentially a mirror image study involving two groups of patients, one commercially insured and one Medicare insured, and showing an improvement in the medication possession ratio for the long-acting injectable medications. So here we're looking at sedation, and we see that drugs like clozapine and quetiapine and olanzapine tend to be more sedating than drugs like paliperidone or aripiprazole or lorazepam. Extrapyramidal side effects can be very troubling to patients, can interfere with subjective well-being and potentially even functioning, one of the things that also makes patients look different from their peers. And so here we see drugs like haloperidol, chlorpromazine, lorazepam are more likely to cause EPS than drugs like clozapine, olanzapine, quetiapine, aripiprazole. Weight gain has become a concern, particularly with some of the second-generation antipsychotic drugs, olanzapine, clozapine, iloperidone, quetiapine, but less likely with drugs like lisinopril, amisulpride, aripiprazole, lorazepam. Now, when we look at the risk of lipid and or glucose abnormalities with antipsychotics, this review suggests differences amongst some of the antipsychotic drugs. So, for example, aripiprazole and lisinopril are at the low end of the spectrum, whereas clozapine and olanzapine are at the high end of the spectrum. The next slide, we're looking at change in the QTc, and we do see differences between Sertindole, amisulpride, ziprasidone, and drugs like lorazepam, aripiprazole, and paliperidone in terms of their propensity to cause changes in the QT interval. Prolactin, again, another example of an adverse effect which will vary depending upon the medication that's chosen. We see paliperidone and risperidone, haloperidol at the high end of the spectrum, aripiprazole and quetiapine at the low end of the spectrum. So, in conclusion, I think we would want to emphasize that the antipsychotic agents are significantly more effective for the treatment of schizophrenia than placebo. Some second-generation antipsychotics appear to be somewhat more efficacious than others in improving positive symptoms. However, any efficacy superiorities need to be weighed against large differences in side effects, and the efficacy superiorities tend to be rather small when they do exist. Antipsychotic side effects vary by individual agent, and in addition, patients vary in their vulnerability to experience particular adverse effects. And I would add that no specific adverse effect is going to determine our overall decisions, but we're going to weigh the evidence coming from a variety of different sources related to tolerability, along with opportunities to provide different formulations of a medication, patients' past history, patients' preference. The pooled analyses of randomized controlled trials indicate that long-acting injectable drugs do not reduce relapse rates compared to oral antipsychotics. But if you look at the naturalistic studies, we see that long-acting injectable drugs are associated with a significantly lower risk of hospitalization in comparison to the oral formulation of the same agent. And in mirror image studies, we also see a rather consistent superiority of the long-acting injectable drugs over the oral formulation that the patient had been receiving before. Long-acting injectable medications can improve treatment adherence, can improve a patient's ability to benefit from the medication, and we do need to consider the use of these formulations more frequently than we do now, because rates of relapse and rehospitalization are still really unacceptably high for many patients with schizophrenia.